Good morning. Good morning to everybody. I'm going to go through the debate, simple or complex stenting for distal bifurcation, left main bifurcation. We have different scenarios, and we know that the key of success every time with any scenarios is a good clinical indication to keep it simple as possible. Not always we can keep it simple. Plan your procedure according to the complexity of bifurcation lesion, a stepwise approach every time. Intravascular guidance is highly recommended both in simple and in complex. And of course, lesion preparation, stenting, optimization to get the best outcome. Then the clinical indication, I think we have so many scores to evaluate for any patient. But again, the first step is the good procedure. We start from a good, appropriate indication. Then coming to the bifurcation, the clinical relevance of side branch does matter. Because if you have a small side branch, then covering small amount of myocardium, it is not important to optimize, but keep it open. Well, when you have a big and covering more than 10% of myocardium, then optimization and optimal result should be obtained in order to have to keep the good prognosis for the patient. Second, side branch size, of course, does matter, as well as the side branch angle does matter in deciding whether it is simple or complex. And the lesion length on side branch is also very important. You see from this meta-analysis that when you have a side branch disease extended for more 10 millimeters than two stents, that means complex stenting is doing significantly better than simple stenting, that means provisional stenting. It is an old problem, and you see that from the guidelines of 2011, the indication was provisional stenting is the default technique, but when complex bifurcation morphology, two stents will be preferred. Now, what is complex bifurcation lesion? It is not well defined. European Bifurcation Club is recommending to adopt the Medina classification for clinical use. We know that it is excellent classification to describe the type of bifurcation lesion accordingly to only the involvement of main vessel and side branch, but it is not good to define the strategy for the treatment, because there is no information about the extension of disease, angulation, calcification, and so on. So many characteristics which does matter in selection of strategy. And now, if you look on the recent consensus coming from the European Bifurcation Club, the European Bifurcation Club adding something more to the Medina in order to define the complexity, and this including the extension of disease of side branch as well as the morphology of the lesion. Now, how we select the appropriate approach? I think today we have something more, which is the definition criteria, defining what is complex and what is simple based on two major criteria, on severity of lesion in main vessel and side branch and the extension of disease of side branch, and six minor criteria. So when you have one major criteria with more than two minor criteria, bifurcation lesion is defined complex, otherwise it's simple. And according to this definition, you see that if you are approaching simple bifurcation with simple stenting, this will be superior than complex stenting. But on the other hand, if you had approaching a complex bifurcation with two stents techniques, that means with complex stenting, will be better than provisional than simple stenting in complex bifurcation. And this was also confirmed, including distal left main in definition 2 trial. So to summarize, when in bifurcation lesion, if the side branch is not relevant, just keep it open. If it is simple, defined by definition criteria, simple stenting is the default strategy. And if it is complex, accordingly to the definition criteria, the approach will be complex as default approach. And intravascular imaging, of course, are highly recommended. You see that both IVUS or OCT are now in class 2A for myocardial revascularization for European bifurcation, European Society of Cardiology. And of course, the lesion preparation, it's another important element. That means if you have to debulk where it's necessary to debulk to have the maximum expansion of the stent without any deformation or any malapposition. And you'll to agree with me that without intravascular imaging and debulking, you will never get result like this in situation with diffuse and severe calcification. Now, let's go to strategies. The mostly used are what you see here, simple bifurcation and provisional stenting, then complex stenting with crash, DK crash, mini crash or DK crash, T or TAP, and cool-out stenting. What is different from the past? I think all strategy of bifurcation lesion approaches have been improved because of we have different platform, different designs, more appropriate strut opening and thickness, more detailed data coming from bench testing and clinical practice, more use of intravascular imaging, improvement basic strategies, more criteria to define simple or complex bifurcation according to the anatomy and characteristic of the patient as well, and more clinical data with improved outcome. And you can see clearly that we are not dealing with the old stent, but new stent, that means contemporary stent, can permit us to do things that have not been possible in the past. Now, the simple is provisional stenting, and actually, if you just do very quickly, this can be done in 3 steps. The first is wiring apply dilatation, that means lesion preparation, then stenting main vessel, then pot with appropriate sizing of the balloon, and if you do not have any compromised side branch, the procedure is finished. That is why it is simple. And if you have something on side branch, you can correct that by recrossing and kissing balloon and repot, and all will be in place. And the complex DK crash, again, we have much more steps here, and we have to follow exactly the steps. And you can see again, just to show the stepwise approach in the complex things, starting with defining the procedure with intravascular imaging will help much more than angiography alone. And then lesion preparation are the first steps, stenting the side branch with a balloon in the main vessel, crushing the stent, the protruding stent in main vessel, that is the third step, and then rewiring again. And the step is separate inflation first and kissing balloon, first kissing balloon inflation. And after that, stent deployment in main vessel, pot, rewiring, again side branch, and then separate inflation and second kissing balloon, and final pot, and then the final angio and the final intravascular imaging in order to be sure that everything in place. Also with other approaches like TAP, like mini crash, like DK you can obtain following step by step, you can obtain optimal results as well. The main thing is to follow, to do your procedure stepwise, and to check by intravascular imaging that every step have been completed optimally, which is the gold standard. I think we do not have any gold standard. You see here that from this meta-analysis comparing what we are using today in our practice to provisional stenting, showing that maybe that DK crash might have more advantages than the other approaches. However, if we look on this meta-analysis, again, comparing the same thing, and this is ranking system goes from 1 to 7, the best is 1 and the worst is 7. And you can see that every approach has his pros and cons. And from the most recent trials, that mean EBC main trial and DK Crush 5, can see that there's a big difference in the outcome, but that is because these two trials cannot be compared, since the characteristics of patient included were completely different. In EBC main, the patient included are mostly with the simple bifurcation lesion, while in DK Crush 5 were complex bifurcation. The outcome, the clinical outcome, I think it's clear to all of us. When you have say high syntax score, the surgery will goes better. Otherwise, angioplasty will do a good job. So my conclusion is that key points for patient selection is as we have good clinical indication, the strategy make it simple in simple bifurcation, where upfront strategy is still provisional stenting. However, keep in mind that 20% of these patients will shift to two-stent strategy. Make it complex in complex bifurcation defined by disease extension and severity, and as well as by the anatomical characteristics of bifurcation lesion. Keep in mind that all two-stent strategies have their pros and cons. Optimal one is that well performed and optimized, and of course require good experience, stepwise approach, planning the procedure accordingly to lesion characteristics and complexity, and lesion preparation, good stent expansion of the position, and final optimization. Finally, good operators should have experience in more than two-stent strategy and be ready for plan B, which might be necessary during your procedure. Thank you very much for your attention.
Thank you. I want our moderators to make some comments.
Dr. Sheiban, nice talk. I want just your opinion. While large circumflex artery, dominant circumflex, for provisional stenting from LMC to LED, whether you do a kissing balloon at the end to keep the struts open in circumflex?
You mean in provisional stenting?
Yeah.
Well, actually, if you do not have any compromise on side branch, I think it is not necessary. It's not mandatory, and this is also recognized by European Bifurcation Club today, which was recommending kissing balloon and final pot in every provisional stenting. I think sometimes going or crossing the stent, doing kissing, you might deform something that have been done optimally without kissing. So I would avoid where it is not necessary.
Even if you do a circumflex ostium, left main to circumflex, and large huge LED, type 3 or type 4, what's your status? Same?
I think the main thing is to be sure that you have access to main vessel, that means to circumflex. And that could be tried. You can take a balloon and cross the stent and see whether you have any impediment to cross. Otherwise, I mean, you can leave it without doing anything.
Yeah, before you say that the ostium is not involved, please make sure that you do imaging to be 100% sure that there is no disease in the ostium for your questions, whether dominant LAD, dominant circumflex, things like that. I think that is an important point, whether you need to attend that or not. Dr. Manoj, followed by Dr. Sharma from the audience.
Professor Imad Sheiban, it's wonderful to listening to you. My question is, we all know here that the angiographic assessment of any vessel has its own limitation. So after a provisional stenting, would you just be happy with the flow angiographically to assess the major side branch like a circumflex, or would you consider in the absence of a side branch physiology to just leave the stent alone in the left main TLAD?
So angiography alone will be, you are happy for the side branch assessment, or do you want something else?
No, I'm happy to leave it. I'm happy to leave it. If it's not no compromise there, I'll happy to leave
DK
it.
Crush 6 looked at that, right? You were part of it. FFR versus angio-guided side branch assessment. There is no superiority of FFR-guided assessment of the side branch.
I mean, if you do not have any sign of ischemia, no chest pain, flow ischemia 3, that means you have a good flow and no necessary to touch anything.
Dr. Sharma ji.
Buongiorno, Professor Sheiban. It is about the double crushing or other techniques, is it really very important to cross with the distal strut, proximal strut? Because there is a lot of controversies.
That is another long-lasting discussion. I think all these things are coming from bench testing. I think there is a rationale in DK crush not to cross distally, because sometimes you have a gap between the stent and wall vessel on the osteomocyte branch, and you might cross abluminally. That means outside of the stent, and then when you are inflating your balloon, will cross the stent. So try to cross more proximally in DK crush. In any other procedure, and including provisional stenting, I think without checking with OCT and not with IVUS, you will never be sure where you are crossing. So it is, let's say, it is a conceptual, good conceptually, because coming from bench testing, but we do not have any clinical or any clinical data supporting distal or proximal crossing.
Thank you. So Karina is the most important thing.
Thank you. Thank you very much, Dr. Sheiban. Fantastic talk.